Good evening, Jailal sir. Srinivasan sir, good evening, sir.
Good evening, sir.
Good evening. Good evening.
Good evening, every senior faculty here and my dear friends. It's 8 o'clock and this has been a long pending request from the students. I was thinking that let us not dilute from the PG clinics model. But then as every student was repeatedly sending mails, asking in person also, and we requested our senior faculty, senior most person here, Professor Rajakumar Khanna sir, to kindly give the talk on the surgical instruments. So this essentially will be touching upon the concept of how to answer the viva in the afternoon. All of them here are examiners for many years. And good evening, Professor Inian sir. Thank you for joining, sir. Professor Inian sir, good evening.
Good evening, Dr. Khanna.
Sir, the first session will be a brief talk by Professor Khanna sir on instruments, sir. By 9 o'clock, Dr. Sushit will be having the case presentation, sir.
Okay, sure. Okay.
Thank you, sir. Thank you.
Thank you.
So, friends, we move on to the talk by Dr. Khanna, and I request all of you to be in mute mode. And Dr. Khanna will be sharing the presentation, and we all warmly look up for Dr. Khanna's talk. Dr. Khanna, sir, it is all yours. Please go ahead, sir.
Okay, good evening, friends. Thank you, Dr. Khanna, for asking me to share some views about a part of the viva of the MS examination, the DNV examination, that is the surgical instruments. My dear all colleagues, Dr. Jailal, Dr. Srinivasan, and all other senior faculty members, and my dear residents. Now, surgical instruments are one of the very important part of the surgeon's life. There is no doubt about that. I think we should not forget this great man, the Sushruta, who is supposed to be the father of the Indian surgery, at least we can say. And at that time, he almost described more than 100 type of the various sharp and the blunt instruments. And we can really say that probably nobody else in the world has described so many instruments what Sushruta described. Now, as far as if you look at from the practical point of view of the examination part of the surgical instruments, usually this comes as a fag end of the examination. There is no doubt about that. Once you have finished your clinical, you have got through your theoretical part, and you are through your clinical examination, and you are coming now for the practical examination. And practical examination, usually there are 4 components which are there. And one of the component is the surgical instruments and the operative surgery. Now, as such, probably this is a very small part of the examination, because majority of the time your luck has been decided on the clinical examination. But if you are at the borderline is there, then this part is very important, because then you can change the face of the examiner, and probably if you are at the borderline, you can get through in the exam. Usually it lasts for a very short time. Usually a single examiner is there for this particular viva, and somehow it occurs after the lunch time, when everyone is feeling sleepy, and then you are having this viva. So though it is very important, but still you have to give full importance to your viva for the surgical instruments. Now, what you are supposed to tell in the exam, whenever there are so many instruments lying in front of you and your examiner is sitting in front of you, he will pick up one of the instrument and tell that what is that particular instrument. So when he gives you that instrument, you must be very careful that how will you hold that particular instrument? Because if we are giving you like a forceps he is giving, so you have to exactly know that how you are going to hold the forceps. Or if he has given you a scissor or a retractor, how you are going to hold that. That is probably one of the first impression of this Viva exam which is there. Second is that you have to definitely identify the instrument, that what type of the instrument is there. And if possible, give the name of the instrument and full name of the instrument. The third part is, what is the material used for making this instrument? Now, let me tell you blindly that majority of the instruments are made by the stainless steel. So you can blindly say that probably this instrument is made by the stainless steel, except the few barring which is there. But now there are new types of the materials which are available, which makes the surgical instrument more handy and more good, more, you can say it is really good working. Then fourth part is the sterilization. Always a examiner will ask you that how you're going to sterilize that particular instrument. And let me again tell you that all the stainless steel instruments and the other materials which are there, except the sharp instruments, they can be autoclaved. So if you blindly say that we are going to autoclave that, you will be okay. Except the sharp instruments and the tubular, like tubes which are there, they are usually by the ETO, by the ethylene oxide. So if you remember these two things which are there, the autoclaving and the ETO, probably you can sterilize almost all your instruments by these two methods, though there are so many other methods for the sterilization of the instruments. Then fifth question is, what are the uses of that? And you have to tell that where you are going to use that particular instrument. Then if there is any specialty of that particular instrument, you may describe to get the good marks. And anything else, like if you find a case of a Langenberg retractor is there, so your examiner may ask that who was Langenberg. You find a Cocker's forceps, examiner may ask who is Cocker's. And then those are the things for getting an extra mark in the examination there. Now, what are the recent changes which has occurred for the surgical instrument which are there? As I told you, the material which is mainly used is the stainless steel. But now we have got the various different material for more sturdiness of the instrument, for the more sharpness of the instrument, like the titanium is there, Vitellium is there, vanadium is there, tungsten is there, polymers are there. So all these various type of the materials are available for making, but majority of the instruments still are made by the stainless steel. Sterilization technique, there are new sterilization technique which is there, and the recent one which is there is the plasma type of the sterilizer, what is called Sterat type of the sterilizer, which can sterilize in a very low temperature in a relatively short period of time. And you can sterilize almost all instruments by that, including the sharp instruments and even your all laparoscopes, all your laparoscopic instruments, they all can be sterilized by the Sterat technique. And then in the recent year, there's a fire of the energy sources. So many new energy sources which has come, apart from the monopolar and the bipolar cautery which is there. Now we have got the sensing devices for the bipolar, what is commonly known as the ligashores, or there are ultrasonic scalpels are there, the thunder beats are there. So different type of the new energy sources are there for the purpose of the hemostasis. And then there are minimal invasive techniques definitely have come in a big way in the last 3 decades for almost all type of the surgeries. Now, basically, you can divide your surgical instrument into 4 types. It can be cutting and dissecting instruments. It can be grasping and holding instruments. It can be hemostatic and the occluding instruments. And it can be suturing instruments. Now, the candidate must know that what are the various parts of any instrument. Like a Caesar is there or a artery forceps is there. In any instrument, there are usually 6 parts which are there. First is the handle. Now, this which is there is the handle here. Then reche. This part which is there is the reche. This is the shank. This part is the shank. Now, shank basically literally means the leg of a person below the knee to ankle. So it is a similar type of the name which is given for that this is called as shank here. Then it is a joint which is there. Then it is the jaws here. And this is the tip of the instrument. So these are the 6 parts of that. Handles or the fingerings, reche, shank, joints, jaws or the blades, and the tip of the instrument. And then like in this forceps which is there, here you have the tip here. This is the jaws here. This is the shank here. And this is the handle grip. And you've got a spring action type here. The joint which is here is a spring action here in this part here. And usually all these instruments like the forceps which is there, you get these transverse serrations which are there. Now these transverse serrations are for the purpose of have a good holding of the instrument. If you hold this instrument from this plain side here, you are likely to fall this instrument. But if you hold it here, you will get a firm grip to hold that instrument there. And then like in this retractor which is there, here if you see here in this retractor, these are the blades here. This is the handle here. This is the shank here. And this is the tip of the instrument which is there. And usually the tip of the instrument which is there is slightly bent. And the reason for this bent which is there, whether you take a Morris retractor or whether you take a Zerni's retractor, there's a bend is there. And this bend which is there is for having a good grip in that area. Because if it is flat is there, and if you apply that particular retractor there on a lever, let us take, then it will slip out. But once this part which is there, the tip which is there, it will not slip out. Now, in any instrument, there can be various types of joints may be there, but these are 3 types of joints which are there. This is called as box joint. Okay, this is a box joint. This is a screw. You can see a screw here, like in a scissors, you have a screw here, and this is a spring action here, like in the tooth forceps, there's a spring action is there. Now, majority of the instruments are having the box type. And the advantage in the box type, what happens that it is can you see my face? Dr. Kanagavel? Are you able to see?
Yes, sir. Yes, sir. We are able to see you, sir.
Yes,
Very well.
Okay.
Yes,
Okay. So, usually in the case of the box type, there is a cross like this is there. Okay, so you can see here that one blade of this goes through the other blade here. So this is a box type, and the advantage of this box type is there that there is no protuberance here. So like if you are putting something like in the depth and you are taking a suture here, then in that case, that protrusion is not there, it's a flat is there. So it will not entangle in that area. While like in the case of the Caesar, say you can see the screw here. And this is mainly for the superficial type of the instruments which is there, where you have not to go into the depth of that. And the spring action is usually for the forceps which is there, or the thumb forceps which is called usually is for the thumb forceps. So majority of the instrument will have the box type of the joint. Some may have the screw type, and it can be spring action type. And then another very important thing which is there is the serrations. Now, if you see the inside of, like, let us say this is a artery forceps here, you can have a transverse serrations like this, or a intestinal clamp which is there, where it is vertical one here. Now, when there are transverse serrations are there, it is the purpose is that if you are holding something like you are holding an artery forceps, then if one serration slips, the second catch hold of that. But if it is here in the case of the vertical type of the serrations which are there, then if it is slips, everything will slip out. And usually these transverse serrations which are there makes the instrument more traumatic as compared to the vertical type of the serrations which are there, which are relatively less traumatic there. And then the third variety, like in the needle holders, you have a jig-jag type of the things. That there are multiple crisscross which are there, and it can hold the needle very well. So basically, based on that, these serrations, you can have the different type of the purpose of that instrument. And then these serrations which are there, it may be throughout the jaw here. But there are few instruments where you'll find that it will be only up to this area here only. Like in a case of sinus forceps, you will find that these serrations which are there will be only in this area, but this all will be the plane here. So these are various serrations. So transverse serrations make the instrument more traumatic as compared to the vertical one. There is no atraumatic as such instrument. All the instruments, whatever you say, they give some trauma. But if you talk in terms of relative type, then the transverse are much more traumatic as compared to the vertical variety. So what makes the instrument traumatic? It is a transverse serration which is there, transverse serrations which are there, the reche. If there is a reche is there here, then that makes the instrument traumatic. And usually, majority of the time, there are usually 3 locks are there here. So you should try to keep, if you are putting an instrument, you should try to put it only on the first one. Then you are thinking that it's slipping out, you can do the second one, but usually the third is usually avoided. So it is always better that you control your bowel or whatever you control by the one lock only instead of using all the 3 locks which are there. And definitely if there's a tooth one is there, like there's a tooth forceps is there, there's a tooth is there, then in that case, it makes the instrument traumatic. So these are 3 things which make the instrument traumatic. If they are not there, if there's a longitudinal serrations are there is no reche is there, and there is no tooth is there, it will be a relatively atraumatic instrument. Now, you can divide the instruments into the various categories, like the draping instruments where you use the towel clips, the cutting instruments, the knife, the scissors, and even the diathermy can be used as a cutting instrument. Holding instruments like the various types of forceps which are there. The clamping instruments like the intestinal clamps or the vascular clamps. Hemostatic instruments like the various types of artery forceps, the vascular clamps. The mops and the swab and your own finger is a very important instrument here. If there is any bleeding is there, your first thing should be there that your finger goes in that particular area to control their bleeding. So that itself is a very important instrument which is there in your hand. For the retraction purpose, which can be handheld or it can be self-retaining variety, and there are various types of the retractors are there. Then there are suturing instruments which are there, which require the needle holder, the needles, and the suture. Then various types of suctions are there, staplers are there, and various types of the tubes are there. So these are the in toto. I will not say in total, there are very few of these type of the instruments because there are so many instruments, it is almost impossible to describe all the instruments, but these are the categories for that. Based on that, you can divide your type of the instruments. And I'm going to discuss only the common instruments which are available to a general surgeon. And these are the things which will be kept in the examination. Now, first thing, I will start with, like any operation which is there. First, you are going to prepare your patient for, or you're going to do the part preparation for that. And the most important instrument which is there is this, what is commonly known as sponge holding forceps. This is called a Forrester sponge forceps. It is also called a ring forceps or sponge stick or the Fletcher type of forceps. This has got a here, it is a blunt end here. This is the area which is hollow here. There are few transverse serrations here, and there's a retch is there in this. So it's usually relatively a long instrument as compared to the other instruments. The size of this instrument varies from about 9 inches to 12 inches. Other instruments which are there is around 6 inches size, common instrument. It can be longer or even the shorter, depending upon whether you're doing a pediatric operation or whether you're doing any surgery in the depth is done, then it can be long instrument. But otherwise, usually the instruments, the open instruments are around 6 to 9 inches size. So this is for preparation of the part. You hold the sponge here, and then it can be used for various other reasons which are there. Like you can hold the gallbladder by that. You can sometimes hold the tongue with that, and it can be used for that particular purpose here. Then next is you are going to drape the patient. And draping is done with the help of the drapes which are available to you, and then use few instruments which are there. And the most common instrument which is used is the towel clip. And this is the commonest towel clip which is used, which has got a very sharp end here. But there are towel clips which has got the blunt end also here at this point, so that they do not damage the skin. And you should be careful that when you are taking that you are not damaging the skin here. That has got a retch here. And this is called a Bacchus type of the towel clip. Okay, the other types of towel clips which are there, it can be Moynihan's type, the tetra forceps may be there, or the Lane's type of the tissue forceps may be there. All these can be used for the draping purpose here. Then after you have draped your patient, then you are going to make an incision. And incision can be made either with the help of the scalpel or a knife, or you can use a diathermy for cutting that. And usually we use this Bart Parker knife which is there. Now this Bart Parker knife which is there, it has got again a serrations here for holding a good grip which is there. Usually it is available in size number 3, size number 4, or there's a long size 3 is there, or there's number 7, it's a cylindrical type of the Bart Parker handle which is there. Now 3 is for the smaller type of the blades. Like you can use this is the 10 number blade is there, or you can use the 11, 12, and 15 blade which is there, which fits over the 3, and the bigger size blades which are there, it fits over the number 4 size of that. So you should have both the 3 and number 4 should be there with you. Like if you're going to make a laparotomy, you will use the size 4. If you're going for a very small operation, like even you're going for the inguinal hernia you're going to do, you can use, or you are going to excise a sebaceous cyst, you can use a smaller one. 11 number is for the stabbing purpose. So if there is a abscess is there, you want to stab that, then you can use the 11 number blade here. So these are the common blades which are used. This is the 11 number blade. It has got the sharp things here for the like incision drainage purpose. 15 is for the smaller operations, and 23 size which is there is for usually for the laparotomy. They come in the foils available here, and all these foils, the industrial sterilization is done either with the help of the ETO, or you can use the gamma radiation for that, for the sterilization of that. Now, this is very important, especially for the first year or second year residents who are there, that how you are going to handle this scalpel here. Now see here, it is being held at the site where the serrations are there. Your thumb is on the left side. Your long finger, which is there, is on the right side, and your index finger there is supporting over that. So this is the way you are going to hold. So it's like holding like a pen. So you are going to hold it like a pen. And when you are making the cut, it has to be cut from the belly. Belly means, like, especially if you are going for the, now this is the belly of that. Okay, this is belly. So you are not going to cut from this area here, but you are going to make an incision from this belly here. So that is the way you are going to make an incision. So you must know how to correctly hold the scalpel handle there. Then once you have made that incision, you are going to hold now the skin with the help of the various forceps which are available. You can call it as a grasping forceps. They are also called as thumbs and also called as pickups. So you can tell your sister, I want the pickup. And for getting that, there are different types of actions which are there. So if you tell the sister that I want this, she will give you the pickup for that. If you tell like this, she will give you the scissors. If you tell like this, then she will give you the needle holder. So your hand action can tell that what is required by you from the sister side. It can be a tooth or it can be non-tooth. The common one which are used are the Adson, the Bonnies, the DeBakey, and the Russian. Now this is the Adson forceps. Adson forceps, there's a very thin jaw is there. It may be tooth or it may be non-tooth. It has got the multiple serrations for the holding purpose, and there's a spring action is there in this area. So this is the commonest tooth or non-tooth forceps which is used for any surgery. Now, how to hold this? Again, see here how it is being held. Again, the thumb goes on the left side. This finger, the middle finger, supports on the right side, and index finger comes on the top here, Jay. So this is the correct way of holding the forceps. It can be plain tissue forceps may be there, or there can be tooth may be there. Then is the artery forceps, and this is commonly called as Spencer-Wells artery forceps, also called as Halsted mosquito forceps when you're using the smaller one, the mosquito forceps. It has got the same things which are there. It's a box type of joint is there. All the transfer serrations are there, and the retch is there. And this is a long one which is there. It is called the Peen's forceps. Now you can see the joint here is the screw joint here. Okay, it's not a box one, it's a screw joint here. Usually you can see the retch here. This is usually in the depth if you have to carry out the holding of a vessel. Then you can use this Peen forceps. Now, how to hold this forceps? This is very important. Now, these handles which are there, the right handle will go in your thumb. The left handle will go on your ring finger, not on the index finger, not on the middle finger, but it will go on the ring finger. And the advantage of that is if you put your two handles like this, you have got a huge range of movement which is there. But if it is here, there will be very less movement will be there. So for getting a good range of the movement, you have to put these two handles in the ring finger and the thumb. And how much it should go inside your thumb or this is the distal IP. So this should go up to the distal IP here, the distal IP here, not proximal to that. It should be up to the distal IP on both the ring finger and the thumb. So this is the way you are going to hold your artery forceps or even the scissors if you're holding. That is the correct way of holding that. And then you can give the support here by your finger. And if it is a curved type of the purpose of the curved type of the things which are there is that if it is a straight line is there, then if you're looking that, you won't be able to see the deep tissue. But if there's a curved is there, then you can exactly see that what you're going ligating. So that is a majority of the time we are using the curved type of the forceps rather than using the straight type of the forceps. And the only disadvantage of this type is there that it requires a little more space to work. If there's a very narrow space is there, then you will use the straight one. But if there is a space is available, then you can use the curved type of the artery forceps. Then this is the right angle instrument, which is there, very commonly used. Again, the similar things which are there, and this right angle which is there, it may be the different angles may be there. So there may be complete 90-degree may be there, or it may 45-degree may be there, or it may be 15-degree may be there. It may be very sharp, it may be blunt, depending upon what type of the instrument you are going to carry out. Then you use the Russian forceps. This is a Russian forceps which is there. And this is used for especially for the vascular surgery. Here it is a blunt type of the thing which is there with a gap here. So if you are holding any blood vessel which is there, like the artery or even the vein which is there will be very less trauma will be there. And then there are very specific type of the instruments like the DeBakey vascular tissue forceps which are there, which are very fine, though they are all traumatic. There are transverse serrations which are there, but they are very delicate instruments which can be used for, especially for the delicate surgery, especially the vascular surgery. Then Alice forceps, you know very well. Again, a box type of thing is there. At the end, there is the tooth which is present in that area. There is a gap in this so that whatever the instrument, whatever the organ which is there, it can protrude through that. So because of this, and also because of the type of the serrations which are there, this makes again a traumatic type of the thing. Then the Cocker's forceps which is there, again, it has the serrations, it has the tooth here, again a box type of the joint so for a very firm grip, you can use the Cocker's forceps. And this described was Theodore Cocker, who got the Nobel Prize for the thyroid surgery. So he has described this instrument. There are so many things which are associated with the Cocker. So that is the last part of your viva. If you are doing really good, you may be asked that, okay, what are the various things you can do with the Cockers? What are the things by which the Cocker name is associated? Then the Babcock's forceps is relatively a atraumatic one. It's a blind type of the thing which is there here. Again, a box type of the joint which is with a Reche here. So it's a mixed type of traumatic plus relatively atraumatic instrument usually used for holding the bowel. Now, scissors can be a straight scissor or a curved scissor. It has got a screw type of the joint here. Usually there is no Reche which is there. And if it's the bigger one, scissor which is there, this is called the Mayo scissor. And the finer scissors which are there is the Metzenbaum scissor, commonly called the Metz scissors. And sometimes in the pot scissor which is used, like if you are going to cut the common bile duct in the vertical direction, you can use the pot scissor. If you are going to cut a blood vessel, then you can use the pot scissor. So these are three common types. There are many types of the scissors which are available, but these are three main scissors which can be used. And then, you can use the suture cutting type of the scissor, the bandage cutting type of the scissors which are there. So this is the Mayo scissor, heavy one. You can have the curved Metzenbaum suture scissors, commonly called the METS. Okay, this is again the Metzenbaum. The correct grip, again the same. Again, I want to re-emphasize, this handle goes in the thumb, this handle goes into the ring finger, and your index finger supports that. So you have a controlled action of the scissors here. Okay, these are few other scissors like the Lister bandage scissors, which can be used for cutting the bandage. Then there are retractor instruments which are there, which can be curved or angled, blunt or sharp. They may be handheld retractors, or they can be self-retaining retractors. Various types of self-retaining retractors which are there available for that becomes a self-retaining, does not require, at least it requires less one assistant to use it. Devers is the common one for the depth. Morris is for the spaceship of the parietal wall. Langenbeck is this one. And when you ask that Langenbeck is the same person who has done the first cholecystectomy or not, there's a little confusion that probably this Langenbeck was a different one, and who did the Langenbeck as the first cholecystectomy probably was a different one. Jana. I'm not sure. I will ask my colleagues here that is that the same one or it's a different one. Now, all these instruments which are there, they have got this in the handle here, there's a gap is there. And the only purpose of this gap which is there, it is not for holding the instrument, but it is for making the instrument lighter. Because these instruments, retractors, are quite heavy. So you want to make it lighter. That is why there's a gap in the instrument is there. And then this journey is very common. And the purpose of this type which is there is when you're closing, like the end of the abdominal wall is there, where you can see when you're passing the sutures here, then in that case, you can see that it is at the end which is there. If you are using this one, probably you cannot see the end of that particular suture line, especially when you're doing the abdominal closure. So this end will be used at the end of the closure of the incision. Then there can be ribbon retractor, which is a malleable retractor. You can change into various shapes. It can be the stainless steel. It can be the copper one. Copper one is really good one. So it can take any type of the shape, whatever you want to retract. And then this type of the Park instrument, which is there, especially for the thyroid surgery, you can use this for retraction of the flaps. Cushing vein retractor, which is there, you can retract the vein, you can retract the artery, you can retract the nerve. It has got a sharp U-shaped hair in which that particular longitudinal structure will fit in here, and you can retract that. And then there are various types of the self-retaining retractors. Like one of the famous one is the Belfort type of the retractor, which is there. It can be along with the Doyne's retractor, it may be there. And you can retract the various part. You can retract the bowel, you can retract the bladder for the purpose of that. Then, like Witt-Lerner retractor, which is there, what is very commonly called the mastoid retractor, which can be used especially for like when you have to retract the skin along with the deeper structures and in the way that you do not traumatize that particular area. Then there can be different types of clamping and occluding instruments. This is the Doyne intestinal clamp, which is there. Now, this clamp, which is there, again have the box type of the thing, which is there. The ratchet is there. There's a long handle, which is there, so that you can take a long piece of the intestine. But the serrations which are there, here they are, the vertical serrations are there. Okay, they are not the transverse one, but they are the vertical serrations. So relatively, it may become a atraumatic one. Again, various type of the other instruments which are available, especially like the Satinsky, the DeBakey vascular clamp, which are there. For the vascular purpose, you can use this. You can have the DeBakey type of the bulldogs may be there, again for the vascular purpose. And then the sinus forceps, which is there, you can see here the sinus forceps. See, in the sinus forceps, These serrations are only the tip here. It is not in the complete area here. And there is no rete. So this is the difference between an artery forceps and a sinus forceps. Like when you're doing the Hilton's method you are carrying out, then you can use the sinus forceps. Okay, Desjardins choledochoriothorping forceps is there. It's a curved type of the instrument. And at the end, there's again a hollow which is there. It's a blunt type of the thing which is there, so that you do not crush the stones used for the CBD stones, and even can be used for the ureteric stones also sometimes, so that you do not crush the stones and you can malleate it toward the proximal end as well as the distal end to remove the stones. Then there are various types of suctions and the aspirators which are there. Like the common one which is used is the Yenkor Keor type of the thing. It can be Frazier type here, especially, like if you're doing a very finer surgery you're carrying out, then you use this Frazier type of the suction tip, or you can use the plastic one here. Okay, these plastic one are also available. Then coming to the suturing instruments which are there, you require the three things for that: the needle holder, the needle, and the suture material. Various types of the needle holders which are available. And as I told you that in the needle holder tip which is there, it is a jig-jag type of the thing is there. And then there can be gap in the central part here, so that the needle which is there, it fits into that gap here. And the way of holding the needle here is that you should hold the needle 2/3 and 1/3. So 1/3 toward one side and 2/3 on the other side. And that makes the best grip for holding the needle here. Okay. So again, for this, you can use the different, same thing here. So all the handle instruments has to come to the thumb and to the ring with a support from the index finger. Is a Krylwood, the fine instruments which are there, the Krylwood needle holder is there, or various other vascular needle, the DeBakey or the Mayo Hager needle holders, which are there for the finer work. And then a little bit about the needle which is there. I think you should know a little about the anatomy of the needle. If this is the needle here is there are different things, what we call it. What is the needle length? The needle length, if you measure from here to here, this is the needle length. And this is the cord length. It's just like a breast lump which is there, and you are going to measure it with the, you will not measure it like this, but you will measure it like this. Same thing which is there, that from tip to the eye, this is called a needle cord length, and this is the total needle length which is there. And then definitely the needle diameter, that how thick this needle is there, whether it is Swaz needle or it is non-Swaz needle is there, and what is the various type of the needle point which is there, and what is the type of the needle radius which is there. You have to decide that what type of the needle you are going to use for the particular purpose. So there's the eye is there, the body is there. So there are three things here: eye, the point, and the body of the needle. The eye can be like a closed eye, it may be there, which is measured like just our home type of the needles which are there. Similarly, you can have a hole here, but you can have this one here there, that where you put your thread over that, and this is the French eye. This is called the French eye. While the Swaz one which is there, this will be like a non-traumatic needle which is there, that it is laserized usually, the thread which is there in the needle itself, so that you do not get any extra thing which is on the outside, because this will make a thing traumatic like this, but this will be relatively a non-traumatic type of the needle here. Various shapes which are there. For the abdominal surgery, majority of the time we use the 3/8 circle or the half circle needle, but there are various type of the needles which are available for the various purposes here. And then depending upon that, whether the taper point is there or the reverse cutting needle is there, the cutting needle is there, depending upon that, what is the type. When you do a cross section of that, you can find out that what type of this particular needle is there. Okay, so there are various type of the needle points which are there, and you can, even when you open a suture strip which is there, you may find these various symbols which are there. Like this will be for a taper point, this will be for the cutting edge, this will be for a reverse cutting edge. This is shown over that particular wrapper which is there of a suture material. Now, regarding the suture materials, they can vary from number 5 to 11.0. 5 is the thickest one, 11.0 is the thinnest one which is there. They can be natural, synthetic, braided, non-braided, absorbable or non-absorbable. See, this is the wrapper of that. And see here it is there, that it's a rounded one which is there. So it gives the length of that how much is the length is the 90 centimeter. This is the code number which is there. The type of the suture material which is there, the vicryl is there. What is the length of this is the thickness of that is the 20, and the needle which is there is the 30 mm, the half circle. So all these things, they are written over the wrapper of the any suture material. Then there are various types of staplers which are there. You can use, usually the common staplers which are used is the linear cutter which is there, or there can be TIA stapler may be there, or the linear cutter may be there. There may be the EA stapler for, especially for the, when you're doing the anastomosis after the LAR, then you can use this EA stapler, or even for the esophagus, it can be used. And then definitely we are nowadays using a lot of the skin staplers which are there. And these skin staplers, it has got around 35 the staples are there. So you can just close your abdominal wall only with the one stapler which is there, and it is very fast. Then instruments for the minimal, I will not go in detail of that. But usually the instruments which are there for the laparoscopic surgery, they are the longer instrument. The common size which is there is around 33 to 35 centimeters. Jaws to be adequately elastic to perform the atraumatic handling. They should be easy to disassemble and reassemble. The parts should be interchangeable. So the handle, you can put either Maryland forceps in that, or you can put the hook in that. You can put a spatula in that. They should be interchangeable as far as possible. They should be easily cleaned and sterilized. Now, for the sterilization purpose, which is there for all the laparoscopic instrument, now there are companies who are making a complete autoclavable, except the camera which is there, you can completely sterilize with the help of the autoclave, but otherwise you require the chemical sterilization for the laparoscopic instrument. And they should be with a simple design with minimal number of the hinges and the bolts in the instrument. So this is the trolley set. This is the varus needle. Everyone knows that what is the varus needle. Varus needle is around 6 inches in long. It has got the 2 millimeter external diameter, and it should be held like a dart. These are the various parts of this is the tip of that, the body of the instrument which is there. It can be rotated here, and there's a joint, various type of the handles which are there, like the pistol type of the handle and various other types of the handles which are there. I'm not going in detail of these because I mainly wanted to touch about the open instruments, but these are various trocars which are there, 3 millimeters, 5 millimeters, 10 millimeter, 12 millimeter, disposable and the non-disposable type. Various telescopes are there, 3 millimeter, 5 millimeter, 10 millimeter, or the various angulations which are there. Maryland forceps is one of the commonest instrument which is used for the dissection purpose. Various type of the bowel graspers which are there, and the other type of the graspers are available. Various type of the endoscopic instrument which are there. Hook may be there, the spatula may be there, needle may be there. Then endoscopic applicators are there for putting the clips. Various types of clips may be there. Usually the LT300 and LT400 are the size. The common one use the LT300, and this is a relatively larger one, the LT400, for clipping mainly like the cystic duct and the cystic artery. Then endoscopic crocodile forceps for taking out the gallbladder after the laparoscopic cholecystectomy. There may be endoretractors which open up, and there are various types of endoretractors available, especially for the bariatric surgery. You want to retract the liver, then these instruments can be used for that. And then these monopolar cauteries were there for a very long time. And this is also called a Bowie. Bowie is the American one, American scientists who are there. So this is also called the Bowie or the cautery which is there. And monopolar cautery may be there, or there can be bipolar cautery, and bipolar cautery definitely is more precise with a minimal lateral spread which is there. The ligashore is the bipolar cautery with a sensing device. It can coagulate up to the 7 millimeters diameter of the any vessel. And then harmonic scalpel is based on the ultrasonic power which is there, and it can also seal up to the 7 millimeter. It can cut and cauterize the tissue. The various types, the tubes and drains can be there. Again, blindly, if there is any transparent tube which is there, you can say it is made by the PVC. The other material which can be there is the red rubber, the latex, the silicone, the siliconized type of the latex which is there, the other one. But if the transparent one is there, you can blindly say that this is made of the PVC. Now, the Romovac drain which is there, this is a drain majority of the time used after the abdominal surgery. Foley's catheter is there, which can be bilumen one or it can be trilumen one. And for the urinary catheterization, then there can be a rise tube may be there for the decompression of the stomach, for the feeding purpose, and for giving the gastric lavage. Now, this rise tube is usually 100 centimeter in length. There are certain markings which are there, like at the marking 40, 50, 60. 40 is the first marking which is there. It means it is at the cardioesophageal junction. 50 is in the body and 60 at the pylorus. So majority of the time, you are going to put your rise tube tip at the 50 to 60 centimeter. There are lead pellets which are there at the end of that. And this is to make a rise tube a little heavier one. But the main purpose is to know in the X-ray that where the tip of this rise tube is there. And then there's a green lining which is there all over, which runs to again track the rise tube that where it is going to. And then there's a Kehr's tube is there. Usually the Kehr's tube is a T tube which is there. It has got the very long horizontal part here, but usually you never put such a long horizontal part. This, if it is going in at the site of the colloidocotomy here, the proximal and the distal part may be only about 2 to 3 centimeter. It should not go on the proximal side in the right or the left hepatic duct, but it should remain in the common hepatic duct here. And this part, the distal part which is there, it should not touch the ampulla of the Vater. So you should make it very small hair size, 2 centimeter on this side and 2 centimeter on this side here, and not the whole length which is there available. Again, made up of the PVC, and then again the latex and the silicone are there. Now, for the disinfection, there are various types of the sterilization procedure which are there. It can be high pressure like the autoclave, oven, glutaldehyde, radiation, ethylene oxide. As I told you, all instruments except the sharp instruments and the funnel instrument which are there, they can be autoclaved. Sharp instruments and all the funnel instruments can be gas sterilized. And if you got the facility for the steroid which is there, you can sterilize all the things. So all surgical instruments can be sterilized with autoclaving. Sharp instruments, the tubular instruments by the ETO. So this is the autoclave which is there, usually works at this 121 degrees Celsius at the 15-pound pressure for about 15 minutes it will take. And then this is usually given up, but still for the short-term disinfection, it will not cause the asepsis, it will not cause, but it will only for the disinfection purpose. You can still use Sidex. And if it is there, you should keep your instrument at least for 6 to 8 hours, not the 10 to 15 minutes time. It should be at least for 6 to 8 hours if you really want to have a good sterilization. And then the formalin was there, but formalin used to, there are various problems with to the instrument. It may corrode that instrument and that is why usually it is not used, but still in the smaller capacity, it is kept in almost all the operating rooms here. And then electric boiler, it is almost given up, but still it can be used. And now this is the most, which one, there is the sterate which is there. Now this sterate which is there, you can put almost all the, you can put all the laparoscopes, everything can be put in this chamber here. It has got a large size here. It works at a very low temperature, around, it is only about 50 degrees Celsius as compared to all others which are at least working at more than 100 here. And hydrogen peroxide which is there, the peroxide which is there, and the low temperature gas plasma, there's an interaction in that. And you get this total process time is around half to 1 hour for the sterilization. So this is a good instrument if it is available, though it is a very costly one. And then you have the ETO sterilization, which is there. For the industrial sterilization, you can use the ETO sterilizer maybe there. And as I told you, all the sharp instruments and the funnel instruments can be sterilized in the ETO. So my dear students and my dear faculty members, I will definitely like to have your opinion about the various surgical instruments, which I have tried to cover in about 1 hour time. So finally, to conclude that surgical instruments are the lifeline of a surgeon. Good quality instruments make a difference. Proper selection of the instruments is a must. Instrument must be handled delicately and tissue must be handled delicately. Thank you very much.
Thank you, Professor Khanna, sir, for making such a lively and exhaustive presentation in one go. Now, I would like to hear from senior faculty here.
Yes.
We have Professor Abhay Dalvi, sir. Would you like to chip in, sir?
Yeah, good evening. As usual, Dr. Khanna has been excellent as far as the presentation is concerned. And I think the students who are attending must have learnt a lot. So all the best to the students. That's all.
Thank you, Dr. Dalvi.
Thank you, Abhay, sir. Jailan, sir, please.
Dr. Jayalal is traveling.
Possible, sir. Dr. Rajiv Sahai, sir. Professor
I think
Hitesh, sir.
I think it was a very good talk. Excellent. Very comprehensive. I think very good for the students. I myself will go back and listen to this talk again over the YouTube.
Okay,
Excellent fun, sir.
Thank you.
I think not only for students, to teach the PG students, it was a
Yes.
good presentation, sir. I must tell you, and it was excellent to learn few things which probably many of the teachers might not have known or might have forgotten. And your presentation of how the action of different joints and all works, it was really good. Thank you, sir.
Thank you.
Professor Inian, sir, are you with us?
Yeah, it was a excellent talk, sir. And the tips that were given, in terms of the instruments, it's not only the instruments, but also how it works. I really enjoyed it. So thank you, sir. It was an excellent talk.
Thank you very much. Thank you.
So
Can
it
I
was
come in?
indeed, very, very good presentation, very comprehensive presentation. Because most of the time, you are very well stressed about the autoclaving part, sterilization part. Because in the most of the PG examination, when we are asking about this, they will identify the instrument, they will even say the use of the instrument. But the process of disinfection, the process of autoclaving, the process of sterilization, and there, most of the time, the students are not doing. I think you have very well emphasized on what are the points to say when an instrument, right from the way they hold it, and the way to the till that how they are going to sterilize it or autoclave it. So there's a very comprehensive, sir. I think it is an excellent thing. This is one of the need of the hour, because now even Tamil Nadu, with this competency-based medical education, the part, the Viva part, previously it was in our university, it was added to the theory mark. Now this is now added to the practical mark. So, and the marks are also increased. Now For the instruments alone, they get the 10 marks. The questions, the time allotted is for 10 marks. So it is very important, both for undergraduate and postgraduate, they identify the instrument and properly say the things. And this is it will be one of the, I think, most viewed YouTube, our PG Clinic session. I'm sure there thousands of students will get benefited by this.
Thank you very much. Thank you.
Thank you, Jailal sir. Now, I would request
I think Abhay sir wants to say something.
Yes, sir. Abhay sir, please.
Yeah, Dr. Khanna has enumerated so many names for the instruments. My suggestion to all the PGs who are attending, especially in examination, please do not try and name these instruments, because tangentially a non-examiner can take you onto the various names of these instruments and get you into trouble. So stick to basics. That's my humble submission.
Yes. Yeah. Thank you, Dr. Abhay.
Any other faculty would like to give comments, or with the permission, we move on to the case presentation. Please advise, sir. Any other faculty would like to add something to this? Okay. Thank you, Khanna sir. I wish you stay back for the case presentation. Sir, request you to kindly unshare, sir. I will call Dr. Shushita to share his presentation.
Yeah, I unshared that.
Yes, sir. Dr. Shushita, are you with us?
Yes, sir.
You can start sharing your PowerPoint, Dr. Shushita.
Yes, sir.
Make it full screen, ma.
Okay, sir. Good evening, everyone. I'm Sushita Nichols from General Surgery CMC Vellore, and I'm doing a case presentation under the guidance of Dr. Enian sir, Professor and Head of General Surgery CMC Vellore. So I will start with the case. 30-year-old lady, a housewife from Ranchi, presented to OPD with the chief complaints of postprandial vomiting for 6 months, abdominal distension for 6 months, irregular menstrual cycle for 6 months, abdominal pain for 4 months, melena for 2 months. History of presenting illness. She was apparently well 6 months back when she developed intermittent episodes of vomiting, non-bilious, non-blood stain, non-projectile, contents were undigested food particles, and it used to occur mostly after 1 hour of ingestion of food. There was history of associated abdominal distension from past 6 months. She also had a history of irregular menstrual cycle for 6 months. Her periods used to last for 3 days, once in 2 months. She also had a history of early satiety from past 5 months. There was history of loss of weight of around 10 kg in 5 months. There was history of diffuse lower abdominal pain from past 4 months, which was sudden in onset, moderate in intensity. It was a vague aching pain, progressive, 3 to 4 episodes per month, and each episodes used to last for 1 hour. There were pain-free intervals in between the episodes. Since past 2 months, she had multiple episodes per month, each lasting for duration of 2 hours. Pain was non-radiating, not associated with meals, relieved with analgesics. There was history of passing black tarry stool, difficult to flush, sorry for the spelling mistake. That was twice or thrice per month for past 2 months. There was no history of regurgitation, heartburn, dysphagia, no history of fever, night sweats, no history of jaundice, clay color stool or dark yellow color urine, or generalized itching, no history of hematuria or increased frequency of urine, no history of bleeding per rectum, no history of intermenstrual, postcoital or withdrawal bleeding. Past history, there was no past surgical history. There was no history of blood transfusions or allergies. There was no diagnosed comorbidities. Personal history, she consumes mixed diet. There was no history of alcohol consumption, tobacco chewing, or smoking. She had normal sleep pattern. She was married for past 8 years. She did not had any children. She had attempted in vitro fertilization in 2021, which was unsuccessful. Menstrual history, she attained menarche at the age of 13 years. Her periods were regular before. It used to last 5 days per month. From past 6 months, she is having reduced flow once in 2 months, lasting for 3 days. Her last menstrual period was 5th of August 23. There was no history of passage of clots. Family history, there was no history of ovarian, uterine, breast, colorectal, or stomach carcinoma in first degree relatives. On examination, a 30-year-old lady.
Dr. Shushmita,
Yes, sir.
could you just summarize your case, please?
So there is a 30-year-old lady, housewife
Right.
from Ranchi, presented with the complaints of postprandial vomiting for 6 months, associated abdominal distension for 6 months, irregular menses for 6 months, abdominal pain for past 4 months, early satiety 5 months, and melena for 2 months.
Vichitra,
Okay, so
all the complaints should be in patient's own language,
Okay, sir.
in layman language,
Okay, sir.
not the postprandial pain.
Okay, sir.
Such terminology should not present it.
Okay, sir.
Okay.
okay, so you have a patient, young patient, with pain, vomiting and pain, vomiting. She presented first with vomiting. No
Yes, sir.
presence of blood in vomitus ever.
No, sir. There was no history of hematemesis or coffee ground
None at all.
vomit.
Okay. And the vomitus contained
It was
undigested food
undigested
particles.
food particles.
And she vomited a couple of hours after taking food.
Yes, sir. Mostly after 1 hour.
So what do you think you're dealing with now?
Sir, we are having vomiting with associated abdominal distension and abdominal pain.
Distension, have you mentioned distension?
Yes, sir.
Distension since?
So distensions in 6 months.
So
But total
In
vomiting
abdomen also,
is
lower
6
abdomen, no?
Distension is 6 months.
Yes, sir. Abdominal pain is in the lower abdomen.
So you
And
want to
pain.
combine
Okay.
these two, the vomiting and the lower abdominal pain?
So mostly with vomiting, we expect the epigastric or upper abdominal pain, not the lower abdominal pain. And
Could you go back to your
two
complaints? Could you
compartments
just
you are
go back to
talking.
your history of your first slide? Oh, no, yeah, that's it. So the next slide, please. Pain, distension, and vomiting, and irregular cycles in 6 months. Anything to do with all this? Can you connect all these three? I mean, is a irregular menstrual cycle important for this for you as a surgeon?
Yes, sir, because she had a complaint of irregular menses, and she's also nulliparous. Married for past
So
8
is
years.
she on any treatment for fertility?
So she tried in vitro fertilization once, which was not
When
successful.
was that?
But
When was
currently
that?
she's not.
No, when was that? When was that?
That was in 2021.
So 2 years back.
Yes, sir.
Okay. Okay.
Sir, one
So-
moment, sir. Dr. Abhay, sir, would you like to ask something, sir? I could see your hand up.
Yeah. See, you have a 30-year-old female with main complaints of non-bilious postprandial vomit. What does it tell you? Can you hear me?
So vomiting is a non-specific complaint, but it can be associated with the esophageal condition.
Why do you think vomiting is non-specific? Why do you think vomiting is non-specific? Is it non-specific?
So it
It
can
is
be
if it is
associated with
non-specific,
multiple
why is it
conditions.
right on the top of the complaints if it's non-specific? Okay.
Your name is
Okay.
what? Shweta?
Answer sir's question.
What is her
Sure.
name?
Vichitra.
Presenter's name?
Sushrita.
Shushrita.
Sushruta. Sushruta, what are the causes of non-bilious postprandial vomit? That is my
Exactly.
question.
Okay.
You
So
can't
it
call it
can
With or without
non-specific,
pain.
right?
With or without pain.
okay, sir. It can
What
be
does it indicate to you?
so they can be
That there is some obstruction
in the
yeah,
esophagus or in the stomach.
stomach. It's around the pylorus where she is, because you were very clear that whatever vomit comes is the food that comes out, correct?
Yes, sir.
Associated with weight loss, significant.
Yes, sir.
What are the causes of non-bilious postprandial vomit with significant weight loss? That's my second question.
So since it is associated with weight loss, it could be a malignant condition.
It could be
Oh.
malignant condition or it can be chronic pyloric obstruction.
Chronic pyloric.
You agree with this?
Is young.
Yes, sir.
Shushrita, she's a young lady.
Yes, sir.
Yeah,
She's
just let me get her on the track.
so sir. So sir.
Now you are saying that there is abdominal distension. How do you classify abdominal distension? It can be central or generalized. Did you ask this patient? Or a sensation of distension? So you have to ask that.
Okay, sir.
Central distension means small intestinal problem. Generalized distension can be generalized intestinal problem or ascites. You agree with
Okay,
me
sir.
or no?
Yes, sir. I'm with you.
Yeah. Now, you are also giving a very significant history of Malina.
Yes, sir.
So how do you, I'm just leaving the menstruation right now apart because you have elaborated too much on menstruation. I'm just leaving it aside. So now connecting non-bilious postprandial vomit, weight loss, lower abdominal pain, abdominal distension. How do you connect all these four?
So it can be due to malignant gastric condition.
Could be. The only thing against this is the age of the
Age
patient.
of the patient.
That's fair enough. You are presenting a case, but it becomes a probable diagnosis. Now you got to fit in all her menstrual problems into your probable diagnosis. How will you do it? Because that is where the whole thing is. I think Dr. Sai will agree with me. It's not getting connected.
Also the pain in the lower abdomen.
Yes, Dr. Jailal,
Yes,
go
sir.
ahead.
Pain also in the lower abdomen.
Shushrita, I just want to ask you, could
Yes,
you
sir.
find out whether the vomiters was acidic or non-acidic?
So she used to say
Can
that
by history
whatever
make
she
out?
used to eat, that only comes out. Like it was never
Okay,
bilious.
okay. No, that's fine. If she vomits on the floor, was a mark left on the floor or not? If she was vomiting, sometimes the vomiters would fall on the floor. So what was it leaving a mark there or not?
Sir, I didn't ask this
You
question.
didn't ask because that is important. Mostly, if it's malignancy, there is achlorhydria, isn't
Okay,
it?
sir.
Suchrita,
And
Yes, sir.
hello.
Yes,
How
sir.
do you differentiate adult hypertrophic pyloric stenosis that from the infantile hypertrophic pyloric stenosis history-wise?
Sir,
Vomiting-wise.
sir, in case of infant, they will have in the beginning of the like after birth itself, they will have a history of vomiting While in case of
Which
adult,
type of
there will be
vomiting will get? Which type of vomiting will get in a infantile hypertrophic pyloric stenosis and
So,
adult hypertrophic?
so we get metabolic alkalosis um, with paradoxical aciduria. It is hypokalemic.
No, I'm talking about vomiting. Projectile, non-projectile, bilious, non-bilious, and why?
I think she has already told us it is non-bilious, indicating pyloric obstruction. Now projectile or non-projectile?
Dr. Shushita, if
So
you are
it's
not
okay.
able to answer,
So,
please tell so. The examiners are here to help you. If you find difficult, you please express.
In adult hypertrophic pyloric stenosis, the obstruction is at the below the ampulla pattern. That's why there is a bilious vomiting.
yes, sir.
And
in infant,
we have
it is
Professor Anand sir. He's the professor and head of the department at Kilpack Medical College, the Department of Surgical Gastroenterology. Dr. Anand sir, your viewpoints, please.
Yeah, nice to join you all. I just wanted to ask only one question to the presenter. You said there is a vomiting after postprandial vomiting with abdomen distension. As the previous examiner asked, did you ask a clear history of distension in the upper abdomen or it's the whole of the abdomen in your clinical history? And how do you want to correlate this distension with your primary history of the patient?
Sir, she just said that she also used to feel her abdomen distended during these episodes.
But your clinical history shows non-projectile vomiting, early satiety with melena. So where do you want to fix the pathology in this patient? Previously, you said esophagus. Am I right?
Yes, sir.
Does the patient have any dysphagia? Did you ask history of dysphagia?
No history of dysphagia, sir.
Then where do you put this pathology? What is causing early satiety or postprandial vomiting with a melena history? Where will you get? And the distension of them. Mind you, you have not examined the patient. It's only history taken. From the history alone, you can tell. Normally, do you get distension in a postprandial vomiting with melena?
Sir, if it is frequent vomiting and the patient is having vomiting for long periods, we can have distension.
Oh.
Upper abdominal distension mostly.
Yeah, correct. See, you ask for a distension in the particular site, you know. Where is upper abdomen or your patient? Where did the patient?
So she used to mostly feel the fullness in the lower abdomen.
Lower abdomen. Okay, okay. Now, how do you want to correlate this? That is what everybody is expecting. Postprandial vomiting, melena, weight loss, significant weight loss, and lower abdomen distension. Okay, just leave it. You just keep this in mind and you proceed. Now, where do you fix the pathology? Just from your clinical history and we will move on.
So it can be either a pelvic pathology also, since she complained of abdominal distension, pain, and irregular menses. Yeah. And it can also be she's also having upper GI symptoms, can be related to stomach malignancy or stomach pathology.
Exactly. We'll keep it there. Now you proceed. If there is no other questions from other examiners, you please proceed. Now we will keep it there. Huh? Okay.
Okay, sir. On examination, she is a 30-year-old lady which is conscious, cooperative, and oriented to time, place, and person, moderately built and nourished. There was no pallor, no icterus, no clubbing, no cyanosis, left supraclavicular lymph node not palpable, no generalized lymphadenopathy, no pedal edema. She had excess hair growth over chin, upper lip, and abdomen. There were no dilated veins in the leg. Her weight was 65 kg, height of 164 centimeter, BMI of 24. Her blood pressure was 110/70, pulse rate of 82. She was afebrile. So this is her abdomen picture. On inspection, there was a visible mass in the lower abdomen. Umbilicus was pushed up. There were no distended veins, no visible peristalsis. All quadrants of abdomen moving equally with respiration. Condition of the skin over the mass was normal. Mass was located in the left and right iliac fossa, hypogastrium, extending up till left and right lumbar and umbilical region. It was approximately 40 into 20 centimeter in size, ovoid in shape. Hernial sites were normal. External genitalia was normal. On leg raising test, the mass becomes less prominent. On left lateral position, there was mass was not falling forward. There was on palpation, there was no localized warmth. There was tenderness present over the abdominal mass. Abdominal mass was located in left, right iliac fossa, hypogastrium, extending into left, right lumbar and umbilicus. Ovoid in shape, 42 into 17 centimeter in size. It had smooth surface. Upper and lateral borders were ill-defined. Lower border of the mass could not be felt. It was firm to hard in consistency. Mass had restricted mobility in all directions. It was non-bilochable. It was intra-abdominal. It was non-pulsatile. Liver and spleen were not palpable. On percussion, there was dullness over the mass. There was no shifting dullness or fluid thrill present. On auscultation, there were normal bowel sounds heard above the mass. On systemic examination, it was normal. On digital rectal examination, there was no melena, no palpable nodes or deposit. On pervaginal examination, her phonesis were full on the lateral side and cervix was normal. Examination of back and spine was normal. Renal angles were normal. So, conclusion, we had a 30-year-old lady with the complaint of postprandial vomiting, early satiety, abdominal distension, pain, melena with significant weight loss and irregular menstrual cycle. And also on examination, we had a lower abdominal mass, which was firm to hard in consistency. So our first differential diagnosis will be adnexal mass or a uterine mass. Second will be a retroperitoneal mass. Hello? Sir, can you hear me?
Yeah, you can.
Yeah, we can hear you.
And last will be lymphoma.
So I have a question for you.
படிக்கிற லட்சணம்.
Hello?
Yes, sir.
Yeah, I have a question for you. So here is a 30-year-old female who presents to you with whatever the history has been told to us, non-bilious, postprandial vomiting, weight loss, etc., etc. Lower abdominal mass on examination.
Yes, sir.
Why did you do ballotment in this patient?
Sir, if the mass is of renal origin, or if she had a ectopic kidney which had developed, which became malignant, maybe on bilateral side.
Now, one. Your renal angles are not full. So now you are extending your diagnosis to a non-ascended kidney with a mass with patient having upper GI symptoms and melena. How do you explain and get these things together?
I should not say ballotable, sir, for the mass.
No, that's fine. Forget the ballotability of this. Presenting symptoms, melena, very important.
Yes, sir.
And then a lower abdominal mass, which according to you goes from right iliac fossa to left iliac fossa to lumbar region. How do you explain these things?
So melena, I will not be able to explain, but since she had a lower abdominal pain and associated distension, plus she had a irregular menses, it could be a mass of pelvic pathology, pelvic origin.
Okay.
And It
And then
can
how,
be,
if it is pelvic pathology, how do you explain the upper GI symptoms?
So Sushita,
Which brings me,
question is basically she has got both. So how do you correlate both together? So that is
correct.
question sir is asking.
Because
sir,
if it is ovarian malignancy, it is going through another channel. And if it upper GI malignancy, it is going through portal channel. How do you get both together in your diagnosis? It's a difficult case. I am telling you, it's a difficult case, and examiners will be very, very kind to you in this case. But still, trying to know your thought process.
So, based on the postprandial vomiting, early satiety, and melena, it can be due to upper GI pathology also. It can be due to gastric ulcer, or it can also be due to malignant gastric pathology. But the other history and examination points towards a mass of pelvic origin. So it can have a if it is a malignant origin in the stomach, it can have a metastasis in the ovarian or pelvic.
So try and combine together and tell me one diagnosis
So
of
it can
carcinoma
be,
stomach.
yes, sir, malignant gastric carcinoma with the Krukenberg tumor.
That's your final diagnosis?
That's my provisional diagnosis.
Yeah, I understand. Provisional or final, you cannot have any other diagnosis in this situation, my dear. So
Okay.
I'll leave it to the other examiners now.
Yes, sir.
But we do understand that this is a difficult case, as doctor said. But why you didn't add this in your differential diagnosis? Now you said no, malignant carcinoma stomach with a Krukenberg tumor. Why you didn't add in the differential diagnosis? You could have well added that also.
Yes, sir. It could be one of the differential
What prevented you from adding it?
I think she was a bit carried away with the mass in the abdomen, but the history that you said, and when you combine these together, I think you cannot give two diagnoses. So that's why sir is asking, why didn't you look at both together? So
generally, Dr. Shushmita, so
Yes,
generally
sir.
in a clinical history and examination, we should try to put all the findings and come out with a probable time. Am I right? Do you
Okay,
agree?
sir. Yes,
Yeah,
sir.
yeah, that's what. See, everything the patient first complained to you was only a postprandial vomiting and the weight loss, significant weight loss, early satiety, and melena. So all these
Yes, sir.
things only the patient's first history. Your examination, then she said distension, and your examination found out lower abdominal distension. These are all the signs which you elicited. But the primary complaint is only upper GI pathology. So you should know to combine all these findings and come out with a probable diagnosis. That is what everybody expects.
Yes, sir.
Sir, can we allow her to evaluate, sir? Because that will give some focus, I think.
Yeah. Fine. Now you continue with your other.
Sushita, can I ask a question?
Yes, sir.
Now, your first differential diagnosis is ovarian versus uterine, is it?
Yes, sir.
So how do you clinically differentiate between an ovarian mass and a uterine mass?
Sir, based on the mobility, ovarian mass will be mobile mostly anteriorly, laterally, but the lower border may not be palpable. If it is big enough, we can feel it in the upper abdomen, in the left and right iliac fossa. Whereas in case of uterus, it won't be much mobile.
Okay, so one is the mobility, agreed. Anything else?
Sir,
Can you feel the lower margin of the ovarian?
no, sir.
If it is a pedunculated one, you cannot feel it.
Yes, sir. If it is a pedunculated and think we can.
Well, the uterine probably will not be. Unless a pedunculated fibroid is there, then it is different. But if the
Okay.
mass from the uterus itself is there, then you won't be able to feel that. And then PV examination, what will be the difference?
Sir, on bimanual examination, we will be able to feel the mass on the lateral fornices if it's a adnexal mass or tubo-ovarian mass.
Mhm.
Whereas
This-
if it is not an adnexal mass, there won't be any fullness in the lateral fornices.
No, you do the bimanual examination, but in fact, one, you are putting a hand in the abdomen and fingers in the vagina, and then you move the cervix.
Yes, sir.
What will happen? If the uterine mass is there, it will be mobile with the movement of the cervix in the same direction
Okay.
where you are moving the cervix. But in case of ovarian, it will be not there. So that is probably the most important examination finding to say whether it is the ovarian one or whether it is uterine one. In which type of the tumor, uterine or the ovarian, you get more of the menstrual irregularities? Ovarian or uterine?
So uterine.
No.
I think she's right. You know, uterine has got the more of the menstrual irregularity as compared to the ovarian. You know? Okay. Yeah.
Which is the
According to your
This is
investigation, is it a retroperitoneal or intraperitoneal mass?
Sir, on left lateral position, the mass was not falling forward. So in that way, we could not differentiate whether it is intraperitoneal or retroperitoneal mass. Plus, it had restricted mobility also.
But you said
So-
the leg raising test, the mass was less felt, no?
Yes, the mass became less prominent. So it was intra-abdominal in origin.
So now let me ask you a question. You have got a patient with GI pathology and possibly a gynecological pathology. You have listed these investigations, HB, TLC, etc., 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 etc. Which is the investigation that you look for to find the primary pathology? I'll make the question more simpler for you. Which gynecological pathology actually invades the upper GI tract to give symptoms which were your primary symptoms of this patient? Or is it vice versa? It's a very logical question to ask you. If you don't know, you say don't know.
Sir, I don't know.
Okay.
No, Dr. Shukla, the question is very simple. What is the diagnostic armamentarium which you use to diagnose your diagnosis, to clench your diagnosis? Whatever you said, no differential diagnosis. Which
Yes,
among
sir.
these investigations will be helpful in guiding you to know the diagnosis among the battery of tests you have shown in the slide? A simple bedside something you can tell.
So we can do ultrasound and UPT test. UPT we can do.
What does ultrasound will clench?
No, one minute. She said UPT. What is UPT?
So that's a urine pregnancy test. But because she has a
You think
history of
pregnancy in this patient is going to give rise to all these symptoms?
So, because she had a abdominal pain, distension, and irregular menses, plus a mass, so we should do UPT also in this patient.
Why? Don't go on a wrong track, my dear.
Okay.
So let's say, let me ask you a question. UPT is positive. Now what? How do you explain postprandial non-bilious vomiting? Let me go get into obstetrics also. Let's say she's pregnant. Forget the mass, etc., etc. Why in pregnancy, early pregnancy, vomiting is non-bilious? Because it is because of progesterone.
Yes, sir.
Okay, so you don't know about it. I know about it. That's forget about it.
Okay,
Which
sir.
of these investigations which are listed is the most important investigation for you? See, you have to decide between a primary GI, upper GI pathology, especially the duodenal pathology with postprandial non-bilious vomiting and melena, which indicates duodenal pathology or pyloric pathology. Post papilla, you are having melena. Otherwise, you are having vomiting, which is non-bilious, correct?
Yes, sir.
And then you've got a palpable huge mass in the pelvis, which is indicating to you that this could be malignancy of the stomach with metastasis in the pelvic region.
So we can
Now,
do
this is a challenging case. Yeah, go ahead.
we can do biomarker test CA-125.
It is normal. When is CA25 done?
So when we are suspecting any ovarian pathology or ovarian tumor.
Which ovarian pathology CA125 becomes more? If you don't know, you say don't know.
Don't know, sir.
Yeah, because CA125 goes up in epithelial malignancies of the ovary.
Okay.
Okay, so tumor marker is not going to really tell you anything. You are a surgeon. You want to
Yes, sir.
relieve vomiting and you want to relieve the pathology which you examined. Considering all this, where is it leading you? Should endoscopy be the first line of investigation? Or since you have mentioned CT scan, should it be the first investigation to be done? Because I think, my
Sir,
personal opinion, USG is not going to tell you anything.
yes, sir. CT to be done first.
Now, when you ask for a CT scan in this patient, how will you discuss with a radiologist? What are you looking for? It's a complicated case. It's not easy.
Sir, I'll explain that we want to look for the any ulcer or any growth in the stomach, and
Go ahead.
we also want to assess the origin of the pelvic mass and if it is infiltrating the other organ.
Go
And
ahead.
we will also like
Why
to
do you want to know? Why do you want to know whether it is infiltrating other organ based on your history? So let me come back here.
yes, sir.
This patient has upper GI symptoms and examination findings are entirely different.
Yes, sir.
When you do a CT scan, which I believe will be IV and oral, taking
sir.
that creatinine is normal, you will talk to the radiologist saying that the symptoms and the palpatory findings or whatever clinical examination findings are not matching.
Yes, sir.
And I want to know what is the cause of abdominal distension, what is the cause of postprandial, immediate postprandial vomiting, non-bilious.
Yes, sir.
Now, if you want to keep these two together with the radiologist, what are you now trying to look for? Because you are stuck on ovarian involvement.
So we want to look at any upper GI pathology which is causing the frequent vomiting and which is also responsible for the melena. And if it
Correct.
can be the primary and the what mass we are feeling is actually the secondary or metastatic.
A CT scan, when oral contrast is given, what will you look for to rule out a upper GI pathology, especially when it's a non-bilious vomiting?
So we will look at the wall of the stomach if there is any
Very
break in
good.
the
Very
wall
good.
of the
Very
stomach.
good. Correct. So let me tell you, the report is thick walled. What else are you trying to look at?
So we will also like to look at any structure at the lower esophagus, like
Nahi,
same
Papa, tu,
structure.
why are you going into the esophagus again and again?
Okay.
Distensibility of the stomach.
Yes, sir.
If it is not distensible, what does it tell you?
So it can also be due to linitis plastica, in which case
Very
the
nice.
stomach won't
Very
be
nice.
distensible.
Now you are actually getting into the line. So once you know that this could be malignancy of the stomach with non-distable stomach, what is the next investigation that you would like to do?
So I would like to go for endoscopy, gastroscopy.
Very good. Now, because it is non-distensible stomach, there is no ulceration, etc., etc. How does an endoscopist help you in getting the correct diagnosis?
Sir, we
What
can
is Wells technique?
Can you repeat, sir? What is?
What is Well technique?
I'm not aware, sir.
Okay, so endoscopist usually takes biopsies at the same level, keeps on digging, because linitis plastica invades into not the mucosa but the submucosa and the muscularis. So you try to go in deeper. Forget about it. Let's not get into all that. Let's say you find a cauliflower growth and you have taken biopsy, it comes with malignancy. Now what?
Now we have probably the primary as a gastric carcinoma, plus
Very nice.
which has also probably metastasized because we have a adnexal mass, ovarian mass,
Correct.
probably.
Correct.
So this is a metastatic gastric carcinoma. We have to first assess. We have to first assess for the if the patient is fit for chemotherapy. We have to first go for chemotherapy. Since it has metastasized, probably we might have palliative intent.
Has endoscopy been done for this patient? Endoscopy? This
Yeah.
patient?
Sushita, why don't you show the investigation, whatever was done? That way.
Okay, sir.
You got it on the slides?
Yes, so these were the biochemical parameters for
go
her.
to the, yeah, okay.
This is a CT scan done for her.
Keep narrating, Dr. Sushita. You tell what is that you are finding in this CT so that
Yes,
it
sir.
keeps
So
the
this is
discussion on.
liver. There is mild thickening in the gastric wall.
Should you need to pass it, you go back and pass it and describe,
Okay,
because it
sir.
is running, so you may not be able to catch up to the speed of the automatic running. Just pause it where you have finding. Yes. So freeze it and describe the lesion. Then you keep running the video.
So there is mild thickening at the lesser curvature of the stomach.
Please tell about the extent. Please tell about the remaining part of the stomach. Please tell us about the content of the stomach, like that.
Okay, sir. Sir, other part of the stomach is normal, and there was gas inside the stomach, and there was no obvious mass in the stomach.
Do you have any food residue in the stomach? You feel the proximal stomach is distended?
No, sir, it was not distended.
So when you read the CT, these are the things people will be keen in knowing about it. Okay. Now you keep moving. You want to freeze it. You please freeze there and describe the problem, what you're seeing.
So there is two heterogeneous mass, a visible probable heterogeneous mass with a lobulated margin. And the intestine has been pushed to the distal side, which means probably this is intraperitoneal mass.
As you go on, you please describe what happens to the vessels. You get to see any retroperitoneal nodes, parietic nodes. What happens to the plane of the swelling? These were the contentious questions you are posed upon. No, the CT is giving you clarity. So please keep talking about those things. Then the examiners will take you further.
So there were no significant nodes in the CT scan. But the intestines, as the mass was intraperitoneal, the intestines were seen behind it. In case of retroperitoneal, mostly the mass will be, the intestine will be in front, and the mass will be
Excellent. Good.
arising from.
Status of the uterus?
So uterus was
one single go. It will be better if you talk. It is a non-pregnant, normal-sized uterus.
Yes, non-pregnant, normal.
With no content in the endometrium, right? These were also a part of the questioning from the faculty. So this imaging helps you to exclude all the discussions so that you narrow down onto your working diagnosis. Go ahead.
Yes, sir. So this was the HRCT, which did not show any nodes in the lungs.
If that's normal, you don't have to waste time on that. Yes, so based on this CT scan, what is your diagnosis, Sushita?
So there is a irregular wall thickening in the stomach with a ovarian mass. So it's a malignant gastric pathology with a metastatic ovarian tumor.
Endoscopy? You have the endoscopy with you?
Yes, sir. I have the endoscopy report.
You can show that.
So this is an endoscopy report which shows a ulceroproliferative mass in the body of the stomach, distal body of the stomach. And the biopsy from this was moderately to poorly differentiated adenocarcinoma.
Seems to be a bleeding lesion. That Melina history is there, but her hemoglobin is 12, surprisingly 12. No?
Yes, sir. She had Melina for 2 months only.
Okay, now you have the biopsy with you. You have the CT scan. What next?
So mostly since it's a malignant gastric adenocarcinoma with Krokenberg deposit, it's a metastatic tumor. So we would like to give chemotherapy to the patient.
Yes, safe way to approach will be to tell that you will discuss in the multidisciplinary meeting, so that nowadays it has become a standard of care for all the institutions.
Yes, sir. After MDT meeting, we'll decide the plan on management.
Correct. So that then also tell the patient and the family will also be part of the discussion. So the pros and cons of you are offering, you are telling you are going to give chemotherapy. And then in the modern era of personalized medicine, we do something more than the regular biopsies also in selecting the appropriate therapy. So please be descriptive on those things. You be the consultant, you take the discussions on the MDT, you expect what the radiation oncologist is going to tell, what a medical oncologist is going to tell, and narrate the care plan so that the patient can make a decision. So you go in that order. That's what the examiners are looking at.
Yes, sir.
So you
I
said,
have a
yeah, yes, sir. Yeah.
What now you know it is metastatic gastric cancer, correct?
Yes, sir.
What are you trying to palliate?
Sir, since it is a metastatic carcinoma, we cannot do surgery first. We have to give chemotherapy.
Patient is Malina.
So, but her hemoglobin is stable. She is vitally stable.
What will happen to the hemoglobin if you give chemo or whatever adjuvant therapy you want to give?
So, if
And she has vomit.
continue to have,
She has no access to food. Nutrition
Yes,
is going to go down.
yes, sir.
So how do you treat any malignancy? There is a framework.
Yes, sir. So, if there is a malignancy which is obstructive or bleeding, then we will first go for the surgery, even if there is a large perigastric
Patient
node.
is fitting in both.
Yes, sir.
So now you decide and tell me.
So, since
So
CT
in
scan
any
does not,
malignancy, let me just complete. In any malignancy, the first responsibility of the surgeon is curative intention by resection.
yes, sir.
If that is not thing, then we come to palliation. The great sentence is, it is to be seen what is to be palliated. Are you trying to palliate the Krukenberg tumors, which is not giving any problem to this patient? No.
No.
So palliation will be now looking at malina or obstruction.
Yes, sir.
Since there is malina, it will be important to locate how I can stop loss of blood.
Yes, sir.
Obstruction can be treated by jejunostomy or whatever it is.
Yes, sir.
You get what I'm hinting at?
Yes, sir.
Okay, now decide the answer and give it to the other examiners.
So, if it is obstructive, then we may plan a nasojejunal tube or feeding jejunostomy. Or if it is bleeding actively, the patient hemoglobin is dropping, then in that case, we will do gastrectomy first for the patient and followed by chemotherapy.
Look, the patient of malignancy, if you have come to a conclusion and you have shown me the slides, this patient can bleed torrentially at any time.
Okay.
Patient is fortunate, you are fortunate. Now tell the examiners, how would you go about planning the treatment? Let's say you have planned a chemotherapy, you started chemotherapy, and then now the patient starts bleeding actively. What are you going to do? It's a complicated case. It's not for actually you. It's actually for surgical gastroenterologists and surgical oncologists for their MCH exam. You are just giving MS general surgery.
So
What is the
we can embolize the arteries supplying to the particular region, and we can prevent bleeding at that particular time.
So let me go back to the CT scan that was shown by, which is the vessel which you think can be embolized, which will stop the bleeding of this patient? I'm just trying to bring to the notice of all the attendants, especially the PGs, that these CT scans in a complicated case have to be studied properly. Whether I can embolize it, not embolize it. If not embolize, what is my next action? You understand what I'm trying to say?
Yes, sir.
Do not get into this patient operatively unless you have no other option. Such other examiners, please take over.
So we can embolize right gastroepiploic artery.
Generally, it is the the largest vessel, which is the left gastric, that is embolized. It really depends on the location of the tumor, etc. So that needs to be looked at in detail with the interventional radiologist, and then you can decide on which one to go with. So that is if the patient is actively bleeding. So the Sushita, basically this is a complicated patient with multiple problems. Obviously, she's got a malignancy, she's got an upper GI problem, and she's got a metastatic disease. So what is the how does this Krukenberg tumor, what is the pathophysiology of this? How does it reach the ovary?
So generally, the Krukenberg tumor is due to the retrograde lymphatic spread from the gastric carcinoma. Previously, it was thought that it can be directly due to direct seeding, but since the tumor has a well-defined borders and it does not breach the border, so mostly it's due to retrograde lymphatic spread,
So you
which
mean
could be the cause of
you mean to say
metastasis.
there is transcelomic spread is a possibility or not?
Yes, sir. Previously thought, but this tumor is usually confined to the ovary and does not there is no breach in the epithelium when we operate the patient. So
Why does it occur more in the premenopausals as compared to the postmenopausals?
so in premenopausal ovaries are functional, in postmenopausal ovaries are not functional.
So what happens if there is a functioning ovary is there?
Usually ovaries are atrophic in postmenopausal areas.
No. In premenopausal, what happens to the ovaries? Every month, what happens?
There is a menstrual cycle in case of premenstrual. There is multiple follicles in the ovary, out of which one of the follicles is selected, and then the cycle of menstruation occurs with the hormonal
Every
changes.
month there is a rupture of the follicle.
Rupture of the follicle.
Okay, once the rupture is there, that area becomes raw. And it has been shown that the malignant tumors which are there, they've got the more tendency for the raw areas. And that is why majority of the time we think it is still a transgenomic spread is there, but that you cannot explain the postmenopausal.
Yes, sir.
So still you will say it's the transgenomic spread, but in those cases where you cannot explain, you will say it's a retrograde lymphatic spread which is there,
Yes,
which
sir.
is opening for the Krukenberg tumor. So are the Krukenberg tumors solid tumors or cystic tumors?
So they are solid tumors.
They are solid. Okay. What is the DIO classification for the carcinoma stomach?
DIU classification.
DIO.
DIO.
What is the classification by the gross examination? What is that called as?
So by pathological examination, we have the Borman classification. We also
that
have a
is the-
Lawrence classification.
Yes. So what is Lawrence classification?
So Lawrence classification, it divides stomach carcinoma into either intestinal or the diffuse gastric
So
carcinoma.
that is the DIO, no?
That is
The
diffuse.
same. Okay. Lawrence is the DIO classification, diffuse
Okay.
intestinal and otherwise. What do you understand by early gastric cancer? What is early gastric cancer?
So which does not involve the complete submucosa of the stomach. It can be the fungating, ulcerative, protruding.
You know exactly or not? Up to what level you say it is early gastric cancer? Are you there or offline?
She has some problems in the internet, I guess.
Yeah, I think her connection is not good here.
Sushita,
I think she's got disconnected.
Yeah,
But actually, this patient she's back.
yeah, she's back. Yeah, she's back.
Dr. Indian sir, you can complete your thing. You are about to tell something, please go.
No, just how she had presented. So this lady, she actually went initially to the gynecologist with a pelvic mass, and they had investigated her, and the gastric malignancy part was picked up as a second thing. So, in fact, she was thought to have an ovarian malignancy, and on CT scan, because the history that Sushita gave, as far as the upper GI, was not so clear when she presented. I think once everything was then known, then I think that history came out. But from the patient actually presented with abdominal fullness, lower abdominal fullness, etc., with loss of weight, this thing, and then she went to the gynecologist and eventually was found to have a gastric malignancy. So I think that was a sequence of events. And Sushita, correct me if I'm wrong. Those were her primary symptoms, right? She had more of pelvic symptoms, and actually the gastric component of it came out later. So that was just for the benefit of the other, just to clarify with the other examiner. So I think because in your history, how you had presented, it looked like she presented with this, but I think it was more of, vague upper GI symptoms with more of pelvic symptoms was the presenting thing. So that was
Actually, it would have been easier if she has narrated the way you have narrated, sir. It would have saved her a lot of questions because she was primarily worked up. That is the way, if she has taken the history presentation itself, things would have been much easier for her to rather than have defending too many things, little out of GI and out of gynec and other things. But anyway, Shushita, the message what Professor Inian tells is one of the very important course correction you have to all the youngsters have to take up, because when you are narrating in the exam, you narrate the same way as professor was telling. So that way it will save your skin. This patient was the treatment history part. If you have narrated in that way, it should have given you a very clear direction for you. History, complaints, yes, number one. When you have said the treatment history, what as Professor Inian was suggesting or was narrating, it will be appropriate for you to limit yourself the number of alternative things which we have tried to bring in, like retroperitoneal, other things could have been avoided, right? This is one important message, especially any student presenting. If you have a good treatment history which is being proper and reliable from the patient, that helps you to get into your course correction mode at that point itself. All right. So faculty, like now that Shushita is back, you can continue the questions regarding the management. I think you'll have to unmute Dr. Shushita.
Shushita, why did you carry out the DHEA and testosterone in a patient? What was the reason of doing that?
So because this patient also had a complaints of excessive hair growth in the upper lip, chin, and in the abdomen regions.
Okay.
So this can also be because of hirsutism. So to rule out if it is of adrenal origin or if it is any tumor which is producing testosterone which is causing these symptoms. We have done the HEAS and testosterone test.
Again, she had
Did you-
presented to the gynecologist first. So that was, again, one of the, reasons why that was done. So,
Did you check for the iris nodule in this patient? You know what is iris nodule?
Yes, sir. There is no left axillary lymph node palpable.
Okay. You know what is a Devine's operation? Gastric occlusion operation for the malignancies? Any idea?
No, sir.
Okay, like your patient is a bleeding patient. Okay, so there's a big mass is there, which you are not able to resect. No? It may be not locally non-resectable mass, but it is bleeding and it is lying toward the pylorus. So what you can do is that you can exclude that part and do a gastrojejunostomy. So that is called the Devine's operation, especially if the patient is, you are not able to resect and it is bleeding is there. So maybe that may control, it will not really control, but it will definitely make the bleeding less because now the food will not pass through that route. So it will go through the gastrojejunostomy.
Yes, sir.
What are the various pre-malignant conditions for the CA stomach?
So it can be a chronic gastric ulcer.
Okay.
It can be a gastric polyp.
Any bacteria?
Sir, H. pylori related chronic gastritis.
So does that cause a carcinoma or does it cause something else?
So that's mostly related to duodenal ulcer.
No, malignancy. Like a marked lymphoma. It is more associated with a marked lymphoma, which is there. Mucosa associated lymphatic tissue, which is there. So the H. pylori can cause that. Now the patient has got the pernicious anemia. Can he develop the malignancy?
Yes, sir. You can.
So if the pernicious anemia is there, where will be the site of the malignancy? Which portion of the stomach will get the malignancy?
The distal.
No, it is the fundus. Okay, classically, it is the fundus of the stomach. So if you find a patient is having a fundus of the stomach carcinoma, you should exclude the patient does not have a pernicious anemia.
Yes, sir.
How do we differentiate between a endoscopic finding for a benign ulcer and a malignant ulcer?
So malignant ulcer mostly will have everted margins. There will be
Go again like any ulcer, the site, size, margins, edge, floor, just like any ulcer, then you can answer that. What will the site for a gastric ulcer, benign, and for the malignant? Location.
so along the lesser curvature.
Is benign or malignant? Lesser curvature
See,
is
the question asked by Dr. Khanna is very, very simple and logical. If you have an ulcer which is benign, what happens to the rugae of the gastric mucosa? And if it is malignant, what happens to the rugae of the gastric mucosa? One spreads, one contracts because of fibrosis. Am I correct, Dr. Khanna? You're asking this question?
Actually, there are many ways you can differentiate between that. So
Simple,
one
simple,
of that
simple
is
things
yeah,
on
yeah,
endoscopy.
yeah, that's right.
Simple things on endoscopy.
Right. So location-wise, if it is a lesser curvature, more likely to be benign. Greater curvature, more likely to be malignant. Size less than 4 centimeter, likely to be benign. More than 5 centimeters is malignant. The edges which are there, they
If
are,
it is everted, then
yes,
mostly
it is
malignant.
malignant. While in the case of benign, they are punch type of the, no? So they are the more deeper cells which are there. And that is why, nowadays the barium is not done, but that is one of the sign which is there, which is seen, what is called the niche of the stomach. Niche. Niche means it's in a wall where there's a small area where you can keep certain things. Now, you want to keep a lantern there. In the old times, the thick wall, there was a big defect which was kept in that area so that you can put your certain things in that area. So that is called the niche. So niche may be there in the case of a benign ulcer, which is not there in that. And then as Dr. Abhay rightly said that, the mucosa which is there. So mucosa which is there is converging toward the ulcer is for a benign ulcer. While for the malignant, it is called a ironing out of the mucosa, where the mucosa becomes thick and stunted.
Yes, sir.
Okay, so that is suggestive of the malignant ulcer. What is the finding of
It's very,
Lannet's plastic on endoscopy?
Kanna sir, I'll just explain to her in a very simple thing for the
Okay.
PGs who are listening.
Right.
When any wound heals, it heals by contraction. So in a benign gastric ulcer, the mucosal folds will come together. Whereas in a malignant ulcer, it spreads. So the mucosal folds will go apart. That is the indication for an endoscopist to know whether this is likely to be malignant. Rest of the findings which you have said about raised everted edges come into picture later.
Yes, sir.
The first thing that you look for in a endoscopy is where the hell this thing is going. If it's converging together, it's likely to be benign. If it's spreading away from each other, it's likely to be malignant. Okay, simple logic it is. Khanna sir, please take over.
Okay. So what tumor markers you will do in this patient? In a case of
So we can do CA 125, CEA also we can do.
okay, you can do a CA 99 also.
CA 99.
99 is more for the pancreas, but it is also for the stomach also. You will do the CA 1 to 5 you will do. You will do the LDH for that. So these are the few markers which you can carry out for the.
Can you get Krukenberg's tumor with any other primary apart from stomach? So Shudha.
So it can be from other malignancy like colon malignancy also, but mostly when it is Krokenberg, 70% of the time it is from the gastric malignancy.
Any extra-abdominal malignancy?
What about breast?
Yeah, extra-abdominal.
Yes, sir. It can be, there can be syndromic
No.
relation between the tumors.
No, not the syndromic one. Not the syndromic one.
Yes, sir.
So you said it is the stomach is the commonest one. It can be the colonic one. And the third comes in order is in the
So
female.
it can,
In the females.
it can be breast also.
Yeah, breast
Breast
carcinoma.
carcinoma.
So breast carcinoma, apart from causing the Krokenberg tumor, which other tumor it can cause? Which may be there also from the stomach. Any other tumor it can cause?
So they can
Again,
be
the commonest from the stomach. Anything in the parietal wall in the umbilicus? What can be there in the umbilicus in a case of CA stomach?
So there can be, if it is metastatic, there can be Joseph Mary lymph nodes.
It can occur in the breast also. No?
Yes,
Sister
sir.
Mary Joseph nodule can occur also in the breast also. No? Calmness in the stomach, but it can occur in the breast also.
So, what will you do for this patient, Sushita? So, what is your management plan? Just to wind up.
So since currently she is not having much bleeding, and her obstruction is also not that bad, so we will first like to give chemotherapy for the patient.
Okay, so assuming there is no bleeding, you give systemic chemotherapy. Is there any role for surgery in this patient? In other words,
Sir, there is no obstruction or active bleeding, so that's why we will go ahead with the chemotherapy.
okay, I'll give you another scenario. Let's say that Krukenberg tumors are much smaller. They are resectable. Okay, patient has got a carcinoma stomach, which is also resectable. All right, and the Krukenberg's tumor is incidentally picked up on a CT scan. Now, how would you then manage that patient? Would you operate?
Sir, since there is already metastasis, first we'll go for chemotherapy, and then only we'll do surgery.
Okay, so you feel there is a role for surgery in patients with Krukenberg, right? If it is resectable, I'm saying, let's say
If it is resectable.
Sushita sir is trying to bring out from you, will there be surgery be an option at all? If yes, at what stage? And if what surgery, what is the extent of the organs you are going to resect? Make it simpler, because no single center has huge experience to give a guideline for a Krukenberg as such, especially in gastric cancer. There have been single largest series can be 10, 5 maximum from a high volume center. So that is the case. There are two schools of thoughts. One which believe surgery should be reserved when it is possible. The other school believes if you can reduce the tumor load, remove the primary, then the drugs do work well. These are the two schools of thoughts. So as a surgeon, you work in a tertiary or quaternary center where you have access to everything under the roof. What will be your work plan?
So we can do gastrectomy for this patient, followed by trial of chemotherapy.
So primarily, you don't want to do anything for the ovary assets, right?
Yes, sir.
But again, as a word of caution, I'd like to bring to your notice, if in case this patient being attempting therapy for fertility, and you're going to do something from now on, I think that part also have to be discussed in the multidisciplinary meeting. With both the ovaries replaced by malignancy, the options are excluded. And then with the background of malignancy, this should be very clearly explained to that whatever therapy, whatever surgery we are intending to do is going to permanently alter her fertility. Next comes the question of survival issues. How long and what is the best possible symptom relief? The disease-free survival quotient does not come in. Overall survival with a decent quality of life, right? This should be the optimal approach for you to advise a therapy for that patient. So in this case, will you offer surgery? I'll already repeat the question. Will you offer surgery? If yes, what is the extent of surgery?
So since the ovarian tumors are large in this case cannot be completely resectable, we'll first
What
do
makes
the
you to think it is not completely removable? Have you seen in their department or in your subspecialty departments ovarian tumors, how they are handled? That is why I was pausing you during your CT scan when you ran the video of the CT sequence.
Mm.
Think about peritoneal status. Think about pelvic deposit status, which you very clearly said in rectal examination, the pelvic examination, you have not noted any deposits.
Yes, sir.
Am I getting you right?
Yes, sir.
There is no peritoneal disease. There is no hepatic disease. There is no ascites. With so many things to your favor,
Mm.
do you still think removal of the ovary will be a technical challenge for you? No worries.
Could
There is
be,
definitely a
sir. There can be rupture.
okay.
Sorry.
You want to take it off in one go. Point is well taken. So Kanna sir, I think you can give a concluding thing, sir. Definitely it is too much for MS postgraduate to take to this level.
Sushita, do you know what is HIPEC?
Yes, sir.
What is HIPEC?
So we debulk the tumor and the area, the regions where the tumor has been metastasized, and then we give chemotherapy intraoperatively to the patient. Intraperitoneal.
What is HIPEC?
What is
What is the full,
HI?
what is the full form of the HIPEC? What is high?
Say tell, don't know. If you don't know, please tell so. No, don't feel bad at all.
Okay, this is
The IPAC is intraperitoneal chemotherapy,
Yeah.
but high is
H stands for the hyperthermic.
hyperthermia.
Hyperthermic intraperitoneal chemotherapy. You know?
Yes.
So, like in the ovarian tumors, which is there, which are advanced ovarian tumors, or even also in the case of the carcinoma stomach, there are few trials where they have done the cytoreduction. This is called as cytoreduction along with the HIPEC therapy. And there have been some advantage of that. But I think your patient, probably the way the CT was there, probably there must be some peritoneal metastasis when you open this patient. So ideally, you should go for a laparoscopy in this patient to see for that. Once there is peritoneal metastasis is there, then probably the story ends at that point, you know, from the surgical point of view. But if it is just the ovarian, if the Crookenberg tumor is there, still you can have a chance to go with the gastrectomy plus excision of the ovarian tumor as much as possible, which can be done. You know? And then you think always of the, if possible, the HIPEC for this patient. So that is the way you can manage. But probably in your patient, probably I think it will be just a simple type of the palliation which will be done.
Thank you, sir. Thank you. Dr. Anand, sir, are you with us? Abhay, sir, will you like to give your comment, sir?
I would be very simple in treatment of this patient because I always look at a disseminated malignancy, what is to be palliated. This patient requires palliation for feeding, and this patient requires palliation for bleeding. This would be my primary concerns. Ovarian malignancy or Crookenberg tumors is of least importance to me. So how would I treat this patient? I would treat this patient for establishing, which she has already done with a growth in the stomach, which explains for vomiting. So now the question comes is whether to put in a nasojejunal tube and start feeding. My next concern is bleeding, melena. I have to prove this melena, and possibly because she's beyond control. If Crookenberg tumor is there, it's T4 and M1 or whatever you could call it. So I would like to stop this bleeding somehow or the other. Hemoglobin is not dropped, so her bone is, making way for the hemoglobin. But I will do some intervention if it comes to that way to stop that bleeding that is happening. So for the which she has not told us, but I would like to do stool examination for blood. That is the way I would go about it, treating. Embolization, etc., etc. There are a lot of things which are with us, which we can do, but we will do it as and when required. Right now, feeding becomes very important.
Thank you, sir. Thank you very much. Professor
You know,
Anand, sir, would you
one of
like
the
to give your
ways,
Yes, sir.
One of the ways to stop the bleeding, which you can sometimes use, is the argon laser, which is there. So you can spread the laser over that tumor and temporarily it will stop the bleeding. You know? So that is one of the ways. Yeah.
Anand, sir.
No, I totally agree with Professor Abhay. Actually, we have to palliate two things. One is bleeding and obstruction. Patient has got vomiting. So some form of nasojejunal tube or gastrojejunectomy would have been helpful. For bleeding, either embolization or the young girl, you can even do, if it is a resectable lesion, go and do a palliative gastrectomy is quite advisable and acceptable also in such scenarios. And that is what. Next is followed by chemotherapy. It will be a good form of palliation for her.
Thank you, sir. Thank you. Dr. Shushita, now that everybody has been asking questions, we normally allow the students to ask questions with all the senior faculty here. I'm sure you have done a lot of reading in the last week or so. Do you have any questions or do you have uncertainties after reading so much and after getting grilled by the national examiners? Would you like to ask any questions to be clarified?
No, sir.
You don't feel bad about it, but you are welcome to ask questions. I'm sure your thought process would have been much streamlined. It obviously would have been reading about all these things. Definitely would have gone back to the journal literature as well. Do you have any thoughts or you feel this is the way it has to be managed after understanding and listening to all the inputs?
Sir, I want to know, like, after giving chemotherapy to this patient only, suppose we are doing GJ for this patient, gastrojejunostomy, and nasovaginal tube we have done for the palliation, and then we are doing chemotherapy. And after this, if the size of the Krukenberg tumor reduces, so what will be the management after that? We will be able to resect the complete thing, or we have to go for
discussing.
I will take this. I will take this question.
Please, sir.
Yeah. So look, when you are treating any malignancy, the first thing that whether you can cure the patient. Cure is only by surgical excision and nothing else. Now comes palliation. Palliation depends on what are the presenting symptoms of the patient. So if it's obstruction, you got to resect and bypass or only bypass. That is the only option for a surgeon that depends on you. Now you have other options like chemotherapy, reduction therapy, etc., or radiation that comes into your fold. The most important thing for a surgeon is to see to it that tumor regresses, I maintain nutrition through the treatment and offer the adequate treatment. So these sort of things come when palliation comes into picture. For a surgeon, the first thing that happens is, if I resect this tumor, do I do palliation? Now, your patient has obstruction as the symptom, gastric outlet obstruction. So I will look at a resection as a possible thing. During that exploration, whether I can remove these tumors is an other option which I have to do a proper morbidity, mortality meeting with the patient, relative, etc., and decide whether I should go in for a major surgery. The long-term survival of this patient is in jeopardy, which also has to be taken into consideration when you discuss these things with relatives, patient, and the other management protocol of chemotherapy, etc. It completely differs if it's another malignancy where there is no GI obstruction. So it's a difficult situation. Multimodal treatment is the treatment of choice in these patients.
Okay, sir.
Thank you.
Thank you, sir.
Can I add?
Please, sir. Please, sir. Please.
I think just one thing that I would also like to add is in gastric cancers in particular, Krukenberg's tumor, metastasectomy for Krukenberg tumor, definitely has if you compare the patients who had metastasectomy versus who have not, there are studies which have shown that the ones who have done better. That is number one. And basically, it is also possible to get, like, this is a synchronous tumor. You can also get metachronous tumor, like, later, once you've done the gastric resection, you can get Krukenberg tumor. Again, they say if you have done a metastasectomy, there is a possibility to do remove those ovaries. So there is a role of surgery in these patients, and particularly with HIPEC, like sir was mentioning, this role is sort of become even bigger. So debulking and metastasectomy still has a role in a young patient, but it may be after systemic chemotherapy.
Point is well taken. Dr. Sushitra, the message from all the examiners remains like this. This is not a common entity, number one. Number two, patient should be the core focus in what best interest is, what is the best effective symptom support and safe way to prolong the survival. Give a overall survival increase should be the approach. As you rightly said, these patients need continued monitoring. Depending upon the institutional protocol, it can be an ultrasound to sequentially assess. But at least now with the FDG PET coming in, the response assessment is based on multiple parameters. Now, I don't want to digress into the other areas. The message is like this: sequential clinical assessment, periodic image-based assessment, and continued rework of the performance status of the patient, and decision about ongoing therapies. Now, even in metastatic gastric cancer, survival of 2 to 3 years have been achieved with personalized therapy. Be aware of those targeted therapies. Now, it is no more TNM-based therapy. It is also based on the receptor-based therapy. So please be aware. Overall survival in many conditions or many ways are now giving better results with monoclonal therapies or the MAP therapies. Immunotherapy combinations have also been addressed to at all. Be aware of all those things. These are all definitely will be your recent advances question or a short note question for you. But overall, gastric cancer therapy is now getting more personalized, and you don't write off telling that this patient does not require or does not benefit from any form of therapy. This should be the overall message what I would like to share. And I hope all the other faculty will also concur with this thought process. And anything else, faculty, or can we call a close? Been definitely a long discussion. After quite some time, we had such an intensive discussion. Thank you, Professor Inian sir, for bringing in this very important dimension to the case presentation. Definitely all of us have learned, and I am sure the postgraduates here have a bonanza of information covering multiple exam questions and exam scenarios covered up in one single go. Tushita, it's a very unique and definitely a sincere effort from your side. Definitely much appreciate on behalf of all of us. We give our appreciation to you and the amount of training you get at the Christian Medical College General Surgery Department. Full credits to Professor Inian sir and to your team. Thank you, Anand sir. Thank you, other faculty, Abhay sir and other faculty for staying with us till such a long time. And I'm sure we will look forward for yet another week of activity. Every Fridays this happens. Next Friday, we have imaging class, like how Kanna sir did the first part of it. That will be done by Professor Rajgopal Shanai sir, the Professor of Surgery from Manipal, Kasturba Medical College, Manipal. And then we'll also have a presentation. Next week presentation is on right iliac fossa mass. We'll share the information shortly. With the permission of all the faculty, I call the session a close. Good night, everyone.
Thank you so much, sir.